Hi, my name's Jerry Kruse. I'm honored to be the president of the Society of Teachers of Family Medicine. It's been my privilege to serve the society over the years in a variety of roles, most recently as a board member and as the chair of the Academic Family Medicine Advocacy Committee. Thank you for giving me this opportunity to serve you, to serve STFM, and to serve the discipline of family medicine. I'm particularly energized to continue the presidential themes of leadership and advocacy that were begun by past President Jerry Hepworth. In the current American healthcare environment and in the current American educational environment, it is imperative that leadership and advocacy are at the top of our priorities. I've been fortunate to serve my academic career at two institutions who were dedicated to educational innovation and to practice transformation to meet the needs of large populations of people. I was a learner at the University of Missouri in the 1970s and 1980s. I learned from mentors like Jack Caldwell and Jerry Perkoff. I learned with many colleagues who have subsequently served the discipline of family medicine with distinction. My current academic home is the Southern Illinois University School of Medicine. The SIU School of Medicine was founded on the principle of curricular innovation, and I've been on the inside of this since the year 2000 as chair of the curriculum committee. 2000 was the year that SIU made the complete switch to problem-based learning and used standardized patients and OSCEs. The educational philosophy at SIU through all of this has been this: if it ain't broke, do it better. As an STFM board member, I've learned that this is also the philosophy of the STFM leadership and staff, a philosophy of continuous innovation and continuous improvement. The STFM committees, Groups On, and the team in Kansas City led by Stacy Brungart have a vision for innovation and always take risks to do things better. This vision is now being realized through a large number of new and continuing initiatives at STFM. On the website, you'll find information about a new educational research alliance, a toolkit for measuring residency competency, a new curriculum for medical student education, resources for community-based preceptor development, and resources for you to be a member of an advocacy network. These are only 5 of more than 40 initiatives that you can find on stfm.org. My presidential function in this area is an easy one: to encourage creative people to make STFM the indispensable academic home for all family medicine educators. The more difficult issues for STFM and for the discipline of family medicine are external to the organization. The continuum of medical education is disjointed. Healthcare in the United States is fragmented, costly, and relatively ineffective. Neither the educational system nor the delivery system encourages students for careers in family medicine. David Walker was the previous head of the Government Accountability Office and the Comptroller General of the United States. He's a brilliant analyst, and his economic predictions are almost always right on. Mr. Walker says this: United States healthcare costs are the highest in the world. We spend 50% more of our economy on healthcare than any other nation on earth. We have above average infant mortality rates and below average life expectancy. We need to dramatically and fundamentally reform our healthcare system. If we don't, rising healthcare costs could bankrupt America. It's the opinion of David Walker that healthcare costs could bring the U.S. economy to its knees. This spells trouble for all Americans, but this spells opportunity for family medicine educators, and this spells urgency for family medicine educators. At STFM, we know and we profess that family medicine education is at the heart of healthcare transformation. At STFM, we know and we profess that our government, our patients, and our learners look to us to develop the workforce that's needed to improve healthcare outcomes and lower costs in America. And so, the external plan of action for academic family medicine and for STFM must be an aggressive one. We have significant important information that needs to be packaged and delivered at the right place and the right time so that healthcare education can be transformed to meet the needs of Americans. What do we know? We know that when the patient-centered medical home incorporates the 4 essential functions of primary care, that healthcare outcomes improve and healthcare costs go down. We know that the most important of these functions is comprehensive care, but we also know that the comprehensiveness of care practiced by our residency graduates is eroding. We also know that when there are structured systems of care coordination and data management systems, that healthcare outcomes improve and costs go down. We know from TransferMed that when there are prospective payment incentives for the essential functions of primary care, that they are incorporated. From COGME, we know that payments for primary care must be increased at least 75% in order for the proper number of medical students to choose careers in primary care so that we have a balanced workforce. From Canada, we know that when substantial care coordination payments are provided to family medicine centers, significantly higher numbers of medical students choose careers in family medicine, and the practices in the family medicine centers are transformed. And so, STFM must take a more aggressive position of external leadership to develop the alliances needed to influence student career choice and to transform our practices. The first alliance in this essential process is within the discipline of family medicine. That alliance is the Council of Academic Family Medicine, CAFM. CAFM has been very effective of late in providing means to unite family medicine educators in very important initiatives. Here are two of these initiatives. The first one relates to leading change in our institution. CAFM is now developing a process to develop a curriculum for leading change, and STFM and ADFM are taking the lead in this process. Also, the advocacy arm of CAFM now has developed a mechanism by which each department and each residency program can participate in a structured advocacy effort. More importantly, CAFM has provided the structure for academic family medicine to have a united voice on important issues. Even more importantly than that, CAFM and the American Academy of Family Physicians can have a very strong voice that can lead to the change that we need. CAFM and the AAFP have their own strategic initiatives and their own legislative priorities, but together they can come to a great understanding of the issues important to each organization and can articulate those to legislators and regulators so that important changes can be made. Having the ear of our legislators and regulators is very important, and we must become their go-to resource. Faculty development in government advocacy is a top priority. To do these things, STFM must take the lead to develop the leaders of the future. STFM has many leadership initiatives, but we still need more leaders. We need to find the leaders who are in hiding. I myself am an introvert who never sought a leadership position. Early in my residency, I was described as painfully quiet. I really only took leadership positions through the encouragement of faculty members and my colleagues. A good example of this, and probably one of the turning points in my career, occurred early in my tenure as chair of Family and Community Medicine at SIU. At that time, I was attending the annual ADFM meeting. The presidential triad, Mark Johnson, Sam Matheny, and Warren Newton, approached me at that time and asked me to chair the ADFM Legislative Affairs Committee. I responded to them that I really had never done any advocacy work and really didn't know much about legislative affairs. They responded to me that they liked the way that I analyzed information and presented it to help change people's opinions about things. So I accepted the position. At that point, I got to know Hope Wittenberg well. I got to know the people on the Academic Family Medicine Advocacy Committee and the various organizations of academic family medicine. This led to my appointment as chair of the Academic Family Medicine Advocacy Committee and a greater role in STFM, and indirectly led to my appointment in COGME. I would have never probably had these positions had someone like Mark Johnson, Sam Matheny, and Warren Newton sought me out to have this position. Here's a second thought on leadership. The new generation of leaders will lead in an entirely different way. Their leadership will be based on group dynamic and information technology. They'll lead in ways that we haven't thought of before, but we see them every day in our institutions and we see them at our national meetings. We need to seek them out, understand how they lead, and support and encourage them to take the leadership roles that really will move our discipline forward and improve healthcare education in the United States. American healthcare is in peril. The situation is urgent, and family medicine, past, present, and future, will provide the best solution. And there is an opportunity that we cannot miss now. I will continue the presidential themes of leadership and advocacy, and I will support STFM's creative initiatives that have served the discipline for so long. And I will support STFM's leaders in their outreach to other organizations to help improve the healthcare educational system. I look forward to serving as your president. I'm honored to serve as your president, and I wish you always the best.